we go on to the second debate. So the procedure of choice for a large refractive macular hole would be dealt by Dr. Daraius Shroff, who is the medical director from Shroff Eye Center, Delhi. And he's going to say that the amniotic membrane is the best. And we have Dr. Abhishek Anand, who's assistant professor in the Vitreoretina department in Regional Institute of Ophthalmology, Patna. And he's going to say that autologous retinal graft is better. So let's get on to these two speakers on this fiery debate.
Good evening, everyone. I'd like to thank Eye Foundation for this opportunity. So I'd like to thank Dr. Chitra for this opportunity. Thank Dr. Ashraf for allowing me to fight this debate in the form of a video. So there's no doubt that the amniotic membrane is the best technique, and we're talking about refractory macular holes. But the problem is that there are challenges faced when we try to use this amniotic membrane. What are the difficulties? It's difficult to see. It's translucent, thin, difficult to see extraocularly and even intraocularly in high myopes, which are a bugbear for our therapy. The sizing is a problem because it's irregular and arbitrary and leads to non-optimal grafting. And the placement is difficult because it sticks to the forceps, difficult to accurately position. And like we discussed, shoving into the hole causes potential RP damage. So a friend of mine, Dr. Dilraj, and I discussed, and we planned to work around each of these steps. And this is a fun movie to show you and share with you. So here it goes. Enjoy the movie.
Surgical toolkit for ham grafting in VR surgery. Dr. Rizzo's group recently described the brilliant concept of human amniotic membrane or ham grafting for recurrent macular holes. However, there's hesitancy in adopting this technique due to difficulty in visualizing, handling, and placing the graft.
Hi guys, hope you're well. So I am going to hold your hand through preparing, making, and roasting the most amazing Christmas roast ham.
Let us guide you through our recipe for ham in VR surgery. We depict a surgical toolkit using 3 S's: staining, sizing, and sliding. First S, staining. It is true that the amniotic membrane is indeed difficult to see. It is white, translucent, and thin. Simply staining it with a few drops of brilliant blue dye solves the problem. Second S, sizing. We need to determine the graft size and then cut it neatly and accurately. We use inexpensive, disposable dermal trephines. We measure the macular hole indices preoperatively on OCT B scan. After some trial and error, we found that the optimal graft size is roughly the average of the sum of the minimum linear diameter and the base diameter. See how easy it is to get the perfectly sized graft with a dermal trephine. Third is sliding. Accurately and atraumatically placing the ham graft is a major challenge. We use a bimanual sliding technique with a Tano brush and a nitinol flexible loop. Let's see a few cases. The 62-year-old lady presented with failed macular hole surgery done 2 months ago. See how nicely the graft slides in with the bimanual technique using a Tano brush and a finesse loop. Post-operatively, the hole is closed. This RD case came post-operatively with an attached retina, but had developed a macular hole and oil emulsification. We did a silicone oil removal and bimanually placed a ham graft into the macular hole. See how beautifully the hole has closed. This was a failed macular hole case who developed a total retinal detachment with vitreous hemorrhage. In such cases, we place the graft under PFO or after fluid air exchange. You can see how we bimanually slide and spread the graft and place it accurately under PFO. Post-operative OCT shows that the retina is attached and the macular hole is closed. This was a very high myope with a posterior pole retinal detachment and a macular hole. In this case, we slid in the ham after fluid air exchange. In such cases, we take the graft size to be twice the MLD. See how scary the pre-op OCT was and how nicely the retina is settled with a ham graft.
Look at this. I mean, luscious. There is no more festive sight than a glazed ham.
With the Triple S technique, we provide you with a toolkit and our recipe for the perfect ham graft in VR surgery.
That was nice, Dr. Daraius.
Thank you.
Excellent video, sir.
On to our next, Dr. Abhishek.
Can you hear me?
Yes.
On the outside, I would like to thank Team I Foundation, Chitra ma'am, and my special friend, Dr. Ashray, and Jatinder sir for giving me an opportunity to express my thought process on closing a large refractive macular hole through autologous retinal graft. And as you can hear from my senior, Dr. Daraius sir, that he's solving a problem. You know, it's still a problem and he's trying to. So there are multiple options available for solving a large refractive macular hole. And the current, and one thing we must know that each one of these techniques has an adequate justification for its use, and data supporting individual results are scarce, and lack of a large randomized clinical trials prevent definitive conclusions to be drawn regarding anatomical and functional outcomes in the long term. Overall, if you compare regarding the closing and the amount of visual acuity gain, they almost compare size to. Today, we are going to compare two techniques. One is the amniotic membrane versus an autologous retinal graft. So we all know that these both are have something to do with a scaffold technique, and as a scaffold, they provide a scaffold for proliferation and crawling of glial cells like Muller cells, bringing the whole edge closure or aiding a type 2 closure. However, autologous neurosensory retinal prefab should not be seen just as a mere scaffold, and I would like to come that you should be seeing it as a super scaffold. Regarding just comparison as a scaffold per se, the problem that Dr. Daraius has just enumerated, it is easy to handle and unroll. The neurosensory graft is easy to handle and unroll than other scaffolds. It is more sturdy than other alternatives. No need to tuck inside the hole, avoiding RP damage, and it is autologous and easily available. Now, what makes NSG a super scaffold? It is integrated, it is vascularized, it is functional, and it is anatomical. Now, what is about this? This is by his own friend, Dr. Dilraj Grewal, and this is that I have taken a picture. What you see is the top picture, and you see that there is the autograft is white, totally white and hyperreflective. But what you see after 2 months of follow-up is that the complete restoration of the outer retinal layers. And this is what is the characteristic of MSG, that if you achieve a closure, almost 60% of these will have a good outer retinal layer, which will not be available with any other scaffold if used in a refractive macular hole. This is another picture taken from this same, and what you see is that in neurosensory graft has integrated, and the white arrows indicate the formation of the outer layers, the ELM, and the ellipsoid and the myojone. This is from another case study, and what you see is the serial pictures from the 2 months and the 6 months. In the top picture, what you see is that there is a defect at the neurosensory graft junction and the host tissue recipient. And at 1 year follow-up, this is a remodeling of this whole thing, and you can see an exact good ELM, ellipsoid, or myojone, and then the white arrow itself indicates that there is some fovealization at the graft tissue. This is a surgery I would like to show. This is a patient who was roaming around. He is a one-eyed patient, and under oil, he has a chronic retinal detachment for 2 years. And this patient had an inferior retinal detachment with a chronic atrophic retina and multiple holes. In this, we planned for a 180-degree retinectomy, and there was a slit-like retinal defect just adjacent to the superior nasal retina, and we fashioned a neurosensory graft, and we put it under the PFCL, and we put it there. Now, why and then we did a direct PFCL silicone oil exchange, and then we put the silicone oil and closed the case. But why I want to show you the case is that unfortunately this patient again came with a detachment, and we had to reoperate him for a shallow detachment, and we operated him under oil. And what we see under the oil is that this neurosensory graft has perfectly integrated with this recipient bed. There is a shallow fluid which is present, and still the graft is not dislocated or anything. So it shows that there is some amount of synaptic connections and integration of the graft around the host bed itself. And this is very important. This is another case of 8 series in which you see that with situation follow-up, there is an integration of the graft host junction, and there is a remodeling that is constantly happening. And this remodeling can happen up till 2 years. There is another regarding the vascularization. Well, many studies are there, and most of them have shown that the periphery of the graft host junction gets vascularized, but the center doesn't, remains avascularization. There is a vascular integration which is also taking place. The same thing is another case, it's confirmed on the fundus fluorescent angiography. Now, regarding the functional gain, we see there are 3 cases in this group. In the top picture on the A side, we see that there is the overall, if you see the multifocal ERG, there is some depression, but there is some functionality present. In the case 1, which was evaluated at 1 month, and then at 7 months, and at 2.5 years follow-up, at 1 month, there was complete or absence of the ERG, but it gradually regains its function. At the 7th follow-up, there's a perifoveal and the centrofoveal is still depressed, but at 2.5 years, only the fovea is depressed and the perifoveal has regained its function. So, regarding everything, that is, there is a concern regarding the graft dislocation, retinal detachment. There is a question.
Doctor, 1 minute left.
Yeah, into functional gain and the surgical learning curve, especially for graft procurement, graft sizing, and transloping to a recipient bed. But in order to counter it, I would just say I'll be asking the right question, and it's a work in progress, and future appears to be bright for NSG. Now, everything is not bright and rosy for amniotic membrane itself. You see this bright tissue which is sitting in between, and this can remain for up to 2 years, which has been and it can prevent the integration of the photoreceptor layers. This is another case series in which in the first top picture, the amniotic membrane has re-rolled, and it causes it failed to roll, and it causes a detachment of due to the lift at the macular edge. In the second phase, there is a contraction of the amniotic membrane leading to changes in the and in the third picture, you can see there is a incomplete opening and closure of the bed, and that leads to atrophy at the place. So if we have to change, so right now we are with the
time over.
With the question whether we want to take this one, which is on the right side, the peripheral retina, and on the inferior side of the amniotic membrane. I would say go for the super scaffold, and you make a wise decision. Thank you.
Brilliant talk. Nice. On to you, Ashay. Let's get the discussion brief. We have 4 more masterclass talks.
As you rightly pointed out, in a retinal detachment, we would want to plug that hole with either of these 2 elements. But in real life, do you accept type 2 closure? Or you want to see that retinal edges bridging?
The question is to whom?
What?
No, ideally you want the best, right? You want the type 1 closure, right? But then I feel that there are 2 techniques of if you go for NSG, and if it gets integrated and you get a complete restoration of the normal anatomy, almost complete, apart from the foveal dip that you are seeing, that will not be present. Regarding the amniotic membrane, there are 2 techniques. One is when you put the amniotic membrane in this, which was shown by sir, and another is you put it like a cap over it, and that will. But even in those cases, almost 100% of cases didn't have the type 1 closure; it has a type 2 closure.
No, sir.
I think the main thing is that amniotic membrane, this is something we're using for very, very refractory recalcitrant cases. I think that's the main kind of take home. It's not that we're going to do this in any routine cases. Very, very high myopic eyes, I think it works well. Other thing is I find, of course, jokes aside, the neurosensory graft also works very well. But I feel cases which have a detached retina, sometimes I feel less worried about cutting a large piece of retina and stuffing it. In attached retina, I still shy from cutting the retina and getting a choroidal bleed. In those cases, I find the amniotic. So I made my own algorithm. Large recalcitrant holes which have failed many, many surgeries. If retina is attached and I don't expect good vision, if it's high myope, I do amniotic membrane. But if it's detached, then I would agree with Abhishek, I would go for a neurosensory graft.
Final word from Dr. Elrias and Dr. Barbara.
Can I ask one question from Daraius regarding his technique?
Yes.
So, hi sir, a wonderful video. Congratulations on that. And sir, regarding your regarding the amniotic membrane graft size, you were trying to almost match it. I mean, you wanted to keep it the minimum, but there are studies which have kept it a very large to a very small. So, so in your case, was that due to the small size, was that the necessity to stuff it a bit inside? Because in all your cases, I could see the amniotic membrane. Because it's a very small size of the...
So it depends on whether you do underlay technique or overlay technique. I did overlay and had my hands burnt because it kind of flew off. So now I do underlay. If you want underlay, you have to kind of balance the size. If it's too large and you do underlay, it kind of crinkles and then it becomes like those horrific cases you showed at the end of your debate that why it failed. So this is the kind of formula which I showed in the video, which gives you the optimal size. It's large enough to kind of cause apposition, but it's not so large that it crinkles inside and folds and causes to close in this odd sort of manner, or it doesn't pop out also either. So that's why I kind of made this formula.
Thank you very much.